it won't be a conventional talk. I'm not going to talk in a conventional manner because I'm sure you have quite good knowledge of the topic. I'm going to give the tips and tricks for the ovarian hyperstimulation syndrome, pointing certain important aspects about the incidence of OHSS according to this European study. The mild forms of OHSS, which most of us meet in our practice, comprise about 33% of patients undergoing IVF. Those who goes to moderate to severe OHSS, about 10% of this value. And we do see quite a good bunch of these patients. And 10% of these goes into the critical form of OHSS that need hospitalization and may need ICU admission. And 3 in 100,000 of the patients, unfortunately, may die. What's the etiology of OHSS? Although OHSS is famous to be iatrogenic, however, it's reported in the literature that OHSS may happen spontaneously in singleton pregnancy and in multiple pregnancy, cases with hydatiform mole. And the tip here is patients with hypothyroidism. خلي بالكم منهم قوي, and these patients are liable for spontaneous OHSS. As for the iatrogenic part, the tip here is that the main theme for the OHSS may be unpredictable. It just falls on our heads under the umbrella of over response. ولازم هنا نقول الكلام ده ونفهمها للمريضة: الاستجابة المفرطة وليس التنشيط الزائد. الاستجابة المفرطة, over response, and this is unpredictable. We cannot measure it, cannot anticipate it before we start our stimulation cycle. But what's in our hand is overstimulation, to give excessive GnRH, to give the excessive gonadotropins for the patient. So this is in our hands. The other thing that's in our hands is the trigger with HCG, which starts the whole cascade of the problem. The tip here is you can have OHSS even when you use clomiphene citrate, and this has been recorded in the literature. But of course, the classic teaching is that in patients undergoing IVF, the PCO patients, when you use the long protocol, you are asking for trouble. And this has been published by my dear friend Boutros Rizk back in 1992. Boutros has published a lot of publications and has books related to this topic of hyperstimulation, either with other colleagues or with my dear professor Mohammed Abulghar, who has classified, together with Dr. Ragat Mansour, the time classification of OHSS, and starting from 24 hours after the OPU up to the first 7 days. And this is due to the exogenous HCG that we give. And characteristic of these patients is they have excessive ovarian response. And most of these patients are mild, although some of them may go to the severe forms of OHSS. But if our patients become pregnant, they will express late OHSS 10 to 15 days later. And these patients may not have the excessive classic ovarian response that we are acquainted with. And unfortunately, these patients go to severe or critical. So Golan et al. Back in 1989 and later on has subclassified ovarian hyperstimulation into degrees to grade 1 OHSS, which is together with grade 2 most of our cases that we see, including abdominal bloating, mild abdominal pain, moderate pain, nausea and vomiting, diarrhea. Together, they are included under the umbrella of the mild OHSS. And in these cases, you find ovarian size usually less than 8 centimeters. But if you go upscale to the moderate OHSS, you find that grade 3, you find ultrasound evidence of ascites, but if you find clinical evidence of ascites, you are running to grade 4 together with breathing difficulties, and you can see the ovaries growing to 12 centimeters. If you have hemoconcentration and excessive tight, tense clinical ascites together with hydrothorax, now you're running for the grade 5, and this is the severe OHSS, especially if you have compromised oliguria, hematocrit value more than 45, hyponatremia, hypoosmolarity, hyperkalemia, that's all under electrolyte imbalance, ovarian size growing more than 12 centimeters. Now you have the severe form of OHSS. And now recently Golan explained or showed the grade 6 OHSS, including the tense hydrothorax, hematocrit more than 55, leukocytic count more than 25,000, oliguria or even anuria, and renal failure, thromboembolic accidents, together with acute respiratory distress syndrome. I'm going to stop here to tell you about a story about this interesting character, the Japanese Admiral Isoroku Yamamoto. He was the designer and he was the manager for the Pearl Harbor attack back in December 7th, 1941 on the US fleet in Hawaii. More than 200 aircrafts attacked, as you all know. And after the second wave of the attack, all the generals knew that it was a smashing victory, and they rejoiced, except for this wise admiral who said, "I fear all we have done is to awaken a sleeping giant." And this phrase became famous for several instances apart from the Navy. And in OHSS, who do you think is the sleeping giant? It is the big V, the vascular endothelial growth factor, and from now on I'm going to call it the V. So this is the initiator of all the storm and the cascade of the syndrome of OHSS. It is the primary mediator and the denominator of severity. The higher the V, the more severe the OHSS. It's characterized by increased capillary permeability, and you can see from its name, it's vascular endothelial growth factor. So one of the publications described the neovascularization into a fenestrated vessel. Fenestrated meaning it allows the leakage of the intravascular proteins to the third space and accumulating fluid in the third space away from the intravascular compartment, causing ascites, pleural effusion, and pericardial effusion. Together with another mediator storms, whether working directly or indirectly as secondary mediators to complete the big picture of the severe OHSS syndrome. But who started the volcano? HCG is the trigger for this storm of the V. It helps the gene expression of the V from the human granulosa cells. It acts in another way. It releases the vasoactive angiogenic substances from the hyperstimulated ovary, primed by the gonadotrophins. So our aim here is to prevent OHSS. The plan of action for preventing OHSS will start by predicting the cases who are going to develop OHSS. We're going to call them the high-risk group, and they start by the design and the decision for you before you start the stimulation. the patients with PCOS, women with history of OHSS, whether mild, moderate, or severe, the choice of the long agonist protocol, antifollicular count more than 50, the AMH more than 3.3, and even if you have started the stimulation, you notice that 15 to 25 follicles are growing simultaneously in both ovaries, measuring more than 10 millimeters in early follicular phase. The E2 level is storming high, reaching as high as 3,500 rapidly. So now you see the red light that you're going to develop OHSS. So how do you prevent this racing car? You can give small doses of gonadotropins and step up simultaneously, the soft or mild stimulation, or even withhold the gonadotropins, what that we call coasting, or use the antagonist protocol and agonist trigger, or you choose to do elective cryopreservation of the embryos and do not do embryo transfer to prevent late OHSS, or you can cancel the cycle altogether. So the mild stimulation, you start with the low dose, the 75 units, incrementing by 37.5 every few days. Take your time, monitor response closely, and trigger when the follicle reaches 17 millimeters. Unfortunately, by the evidence, recent evidence, this is not now a popular way because you get very few follicles very late and may not be reflected on the pregnancy date. In hyperresponder women, mild stimulation has not achieved the wide acceptance, especially in the presence and the availability of the antagonist-agonist trigger protocol and freezing. So now it's not in use. Or you can do coasting. And I've been lucky enough to start these trials and publications by Professor Aboughar with Boutros Rizq. To start the coasting when you have follicles growing more than 20 in both ovaries and the leading ones reaching up to 14 to 16 millimeters, you start by starving the V, starving the vascular endothelial growth factor by stopping the battery charging from the gonadotropins you're giving. And so the smaller follicles go to atrophy and you have only the dominant follicles growing. And you start as well when you find the rising E2. You usually extend the coasting only for 1 or 2 days, because if you extend more than that, you're going to compromise the pregnancy rate. And this very tricky coasting thing, you find that you lose your momentum of stimulation very rapidly, and you end up in dropping levels of the E2 when this is associated with poor oocyte yield. Given also that the embryologists start to complain that they can't see the cameras offers or difficult identification of the oocyte. So currently as well, coasting is not popular anymore as a way to curb the OHSS. Of course, the GnRH antagonist protocol is now in vogue, and it's now almost, as we heard from Professor Robert Norman, is the norm now in cases for predicted to develop OHSS, to give her the GnRH antagonist protocol as standard. The other option is to give the agonist trigger. You have the option to use 1, 2, 3 ampoules, 4 ampoules, different according to the publications. Well, like this one published in May 2020. And it has the advantage, the agonist trigger, than the HCG, because it is short-lived. The HCG has a long half-life. In addition, that the agonist has a flare-up effect, both for FSH and LH. The HCG has only an LH effect. The more important thing is the agonist trigger displaces the antagonist from the receptors, so promise you very adequate luteal phase. The one before last is elective cryopreservation of the embryos. And of course, all of you are acquainted. It eliminates the late onset OHSS, and you can use it both with the agonist and the antagonist protocol. As the last resort, you can cancel the cycle, but mind you that it is the only definite method to prevent severe OHSS and critical OHSS, but it has high financial loss for the patient. She spent a lot of money. She's under psychological stress and deeply frustrating. And I'm intended to use an extra E here because it is deeply frustrating. And believe me, the patient will blame you, will come after you for what happened to her. So this will only be used as a last resort in certain cases with history of being admitted to ICU in previous cycles with OHSS. What about the established cases? I'm going to run rapidly in that. Most of our patients go on the outpatient platforms, whether mild or selected cases of moderate. You encourage the patient at home to have oral fluids for correction of hemoconcentration. You follow up the patient preferably every day and ask her to visit every week. However, if she cannot maintain oral fluids because of nausea and vomiting, you can start her on normal saline IV infusion. But if she still doesn't respond to this with adequate renal function, you have to admit her to give her intravenous colloids, whether albumin or hydroxyethyl starch. But mind you, if you're going to start this, I prefer that you have an anesthetist or ICU specialist by your side. I'm not going to go through details for the albumin and the HES, but albumin is no longer as well in vogue now because being a biological material with all the risk factors for HIV, hepatitis B and C. And its evidence failed to prove that it's effective in preventing severe OHSS. HES is more promising. It decreases the incidence of severe OHSS. It's cheaper and safer. You can use cabergoline, but mind you, cabergoline will not help you in established OHSS. So you better use cabergoline as a protection and started before the day of HCG. This is where you really get the benefits from cabergoline as published by our Cairo University colleague, Mohamed Abdelfatah Youssef. Metformin, it's a very useful medication, as we heard from Professor Norman, as we all use it. It reduces the V factor, and you can give doses up to 1 to 2 grams per day. But it's preferable to start before your cycle with 2 to 3 months. And it's effective in reducing OHSS by 63%, as per our colleague in Cairo University as well, Yahya Al-Faisal. Letrozole had been used, and it's been used in many cycles in our practice. You can use it as an addition to the GN antagonist protocol. What about the thrombosis? This is the ba'ba of OHSS. Unfortunately, it's not a venous thrombosis, it's an arterial clot. Strange enough, it chooses to affect the upper part of the body, the brain, the cerebral arteries, causing hemiplegia and sometimes death. So please mind the thrombosis complication of OHSS. These patients, let them wear stockings and give them low molecular weight. The point and the tip here is you can find this thrombotic threat several weeks after the improvement of the OHSS. The neurological symptoms may present late, even during pregnancy. As regards the invasive therapy, paracentesis. And the paracentesis, the tip here is preserve it for tense ascites and patients with perfusion problems with the kidneys and complaining of shortness of breath. My last few slides will only point to when do you need surgeries. This is very rare to be needed in case of variant torsion, rupture or breaking of the ovaries, ectopic pregnancy. So as a conclusion, and if you don't mind my bad drawings, you can see here that the upper part is the unpredictable part, which is the ovarian response. You on the left side in red, and the patient, especially the PCO patient. So if you're lucky enough and you get this triad at bay, you will not get OHSS. But if the patient starts to float inside the unpredictable and get excessive ovarian response, you are going to get ovarian hyperstimulation. If you are not concentrating in selecting your patients and predicting the ovarian response outcome, you are going to get ovarian hyperstimulation. And at the end, if all of them triad meet together, you're going to face a big ovarian hyperstimulation. So, ladies and gentlemen, my last slide here is our aim. Our aim is to have a successful cycle of ART in achieving pregnancy with a singleton life-term birth, healthy baby safely with no OHSS. And thank you very much.